Today, I'm thrilled to embark on a journey with you into the fascinating world of aware-state endoscopic surgery. Drawing from over 3 decades of first-hand experience, encompassing 10,000 interventions, 60% of which were failback surgery, let us examine the transformative impact that patient feedback during surgery has had in unraveling the mysteries surrounding cervical and lumbar pain sources and the extraordinary advantages that this approach brings to your practice and those in need. Let us look at the benefits of feedback from 3 points of view: endoscopic surgery, pain sources, and diagnosis. Aware state transforaminal probing has been a groundbreaking technique because it has twice the efficacy of discography in pinpointing the surgical target, but also it puts the power in the hands of the patient to guide us directly to the source of their pain. Feedback ensures precise selection of the correct target level, whilst accommodating for variations in nerve plexus formation and enabling accurate targeting in patients with multi-level pathology. Enhanced surgical safety is guaranteed, as adverse nerve manipulation is instantly reported by the patient, allowing for immediate corrective action. With feedback-driven focus foraminoplasty, we're able to minimize trauma and scarring while precisely addressing key pathologies within the foramen, all while preserving natural physiology, anatomy, and function. This is in contrast to conventional surgery, which too often falls short by failing to adequately reach and treat foraminal pathologies. Well, let us examine pain sources in greater detail. Basically, it is the foramen that is the key to spinal pain, because 90% of back and leg pain arises from the nerve within the foramen and not from the disc. Let us endoscopically zoom in on the intricate interplay between nerves and discs. Watch this delicate nerve tethered to the superior foraminal ligament on the left, facing the relentless pressure of a soft, bulging disc. Superficial pressure on the nerve produces midline and paravertebral back pain, whilst deeper pressure causes dermatomal referred pain, spreading outwards and painting a picture of sciatica. Contrary to common belief, it's not the annulus that is responsible for spinal pain. Our extensive studies show that the annulus is only responsible for back pain in 11% of cases, and usually when that disc is inflamed. Transforaminal endoscopic foraminoplasty precisely removes the factors that impact upon the nerve. It decompresses both the foramen and the lateral recesses and mobilizes the exiting and descending nerves by removing facet and vertebral osteophytes, bulging disc, and tethering scar. But here's the catch. MRI scans often miss the presence of scarring and tethering, so look for distortion of the nerve pathway on the MRI scan, where tethering can be seen occurring between the superior foraminal ligament and also between the nerve and the disc. Let us examine these concepts pictorially. The superior foraminal ligament acts like a guillotine onto the nerve, especially where the disc has lost height or the foramen is distorted by spondylolisthesis. When the disc loses height, the facet joints override, and the apex of the ascending facet often develops an apical osteophyte, and both dig into the nerve. As the normal mobility of the nerve is progressively restricted by the scarring between the nerve and the facet joint and the disc, as well as the superior foraminal ligament, the entrapment effect is amplified by the dynamic bulging disc wall pressing onto the nerve. The term instability has become a stalwart of the compendium of spinal pathology. The spine is not unstable, but the concept has become an excuse to fuse, when in fact the symptoms are merely those arising from foraminal impaction and irritation of the foraminal nerve. Such impaction accounts for many symptoms, including the extension catch. Foraminoplasty, by addressing the irritants and compressors of the foraminal nerve, obviates the need for fusion and so avoids the detrimental mechanical effects of such techniques. The take-home message is that foraminoplasty treats both back and leg symptoms. So in summary, the key causes of foraminal pain are the superior foraminal ligament, the overriding facet joint and osteophytes, together with scarring and the dynamically distorting disc wall. But there is a bonus source, namely cluneal nerve trigger point irritation. When irritated, the cluneal nerves can mimic several forms of spinal and radicular symptoms. Trigger points arise from kinking of these nerves as they pass through fascial sheaths, and this is brought on by trauma, obesity, antalgic gait or malposture, or failed back surgery. Cluneal trigger points cause pain, pins and needles, pseudo-numbness, and loss of spatial awareness akin to sciatica. The paravertebral trigger points cause local, flank, and groin pain. The lateral iliac crest trigger points produce lateral buttock and anterior thigh pain, whilst the superior cluneal nerve trigger points are widely provocative. They cause symptoms in the anterolateral thigh and over the tibia. Typically, both the superior and the medial cluneal trigger points produce combinations of local back pain, buttock pain, pain down the hamstring to the calf and even the heel. They represent a potent cause of misdiagnosis, contributing to over 80% of post-traumatic medico-legal claims in my practice, and misdiagnosis in over 30% of patients suffering failed back surgery. So now, having described these pain sources, we need a logical means of diagnosis. So I use a three-pathway diagnostic cascade. This cascade relies upon patient feedback, where displacement of the facet joint produces the patient's symptoms, then clearance of such pain by a CT-guided facet joint block favors facet joint radiofrequency ablation. But be cautious at such an interpretation, because the injected steroid can overflow into the foramen or pass through an incompetent facet joint capsule into the foramen, thus producing misleading results. Therefore, the use of a radiopaque dye at the time of the injection is essential. Where there is no benefit, then the treatment pathway reverts to the surgical treatment options. Where midline spinal displacement reproduces the patient's symptoms, then a beneficial CT-guided transforaminal nerve root block will serve to define the segment involved, leading either to repeat injections or a recommendation of surgical treatment. But again, contrast is needed to ensure that steroid does not track upwards or downwards and provide a false result. Where displacement of the cluneal nerve trigger points reproduces the patient's symptoms, then a palpation-guided steroid injection into the trigger point serves to identify their role. Where the benefit is positive, either the injection can be repeated or radiofrequency ablation produces significant long-term benefit and often serves to save the patient from inappropriate surgical intervention. Where they fail to offer benefit, then the treatment pathway reverts to the surgical treatment options. Thank you for listening. I hope that this digest of my experience will be of assistance to you and your patients, and long may you pursue aware state endoscopic spine surgery, particularly in the form of foraminoplasty.